Good day, everyone. My name is Captain Bartlett, and I am from Martin Army Community Hospital, Fort Benning, Georgia. I'll be presenting a case on SARS-CoV-2 reinfection titled Double the Trouble. Here is my standard disclosure. I would like to add to this disclosure that due to the ever-evolving pandemic process, some of the information contained herein will either be out of date or there will be new up-to-date information that is not included. The objectives that we will cover today will be to describe a case with possible COVID-19 reinfection, discuss the current literature available at hand of immunity resulting from SARS-CoV-2 infection, and present a scholarly question regarding COVID-19 immunity and future opportunities for research. Here's a quick review of our adaptive or acquired immunity that will be part of this presentation, and we will further discuss the second exposure, which will then result in testing the plasma cells, B cells, and T cells that hopefully the first exposure is provided to prevent a reinfection. We will come back to this at a later time. So immunity in SARS-CoV-2, I want you to be thinking about these questions in the back of your mind as we go through this. Does it create a robust response? Does it last? And does it prevent reinfection? Here's our patient. She is a 53-year-old female, medical support assistant at the VA. She has a pertinent past medical history of severe iron deficiency anemia, osteoarthritis, vitamin D deficiency, and seasonal allergic rhinitis. Her first presentation to the emergency department was on 30 March 2020, where she presented with cough, chills, anosmia, agesia, diarrhea, and subjective fever. She had vitals that were within normal limits and was not requiring any supplemental oxygen at that time. She had an unremarkable physical examination and notable labs as seen here. Of note, patient did not have an RT-PCR test for SARS-CoV-2 as it was not available readily at the time. And on CT of her chest, because of her elevated D-dimer, she did have ground glass opacities and bibasilar consolidation. Patient was sent to quarantine, but shortly returned on 3 April to the emergency department at a different institution with persistence of her previous symptoms. She was able to get an RT-PCR SARS-CoV-2 test at that time and was positive. Patient was sent back home to quarantine. Patient then reappeared to the emergency department at 22 April for a new onset dyspnea and worsening fatigue with some continued previous symptoms. She was not retested for SARS-CoV-2 at this time due to her known previous positive, but she did have a chest x-ray with no acute abnormality. Patient then, after coming out of quarantine, went back to the emergency department as requested by her provider to be reevaluated in anticipation for return to work. Notably, she had a repeat SARS-CoV-2 PCR test done at that time, which was negative. Radiology, as described as a CT of the chest, showed interval resolution of previous opacities with some persistent subsegmental atelectasis. Patient was allowed to return to work. However, patient on 2 July 2020 represented to the emergency department with new symptoms since the dissipation of her previous symptoms. These new symptoms include shortness of breath and chest pain. Patient had, as detailed here, a repeat RT-PCR of SARS-CoV-2, which was positive. Patient had a repeat chest x-ray, which did not show any acute process. Patient was again sent to isolate. To round out this patient's presentation, since this time she has since tested negative ×2 for SARS-CoV-2 and her symptoms have dissipated. In recap, we have a patient with two separate symptomatic episodes consistent with COVID-19 illness and confirmed by RT-PCR testing, separated by approximately 3 months with an intermediate negative RT-PCR test for SARS-CoV-2. This leads us into the beginning of our discussion. Does reinfection with SARS-CoV-2 occur? There have been multiple case reports outside of the U.S., in addition to a single case report within the U.S. at the time of writing this report, which have posited the possibility for reinfections. Before we delve further into the possibility for reinfection, let's talk about some of the other possibilities. Viral reactivation. We know that the detection of RNA alone does not confer the presence of a live virus. This has been seen in multiple studies where persistence of viral shedding has been shown without the ability to culture the live virus after approximately day 8 to day 9 of the infection. Next up for discussion is the false positives and false negatives rate. False negative RT-PCR tests for SARS-CoV-2 have been posited to be as high as 30%. False positive rates for SARS-CoV-2 PCR testing range from 0.3% to 3%. This is in the setting of minimal information and a lack of multiple studies that have looked at this, so these values may be vastly different. Studies have shown rates of a second positive PCR result for SARS-CoV-2 from 9.1 to 21.4% in patients who had an intermediate negative result. This is the case for our patient, and they may fall within that 9.1 to 21.4%. Here we again have come back to that slide of adaptive acquired immunity. We will discuss, as seen here below, the plasma cells with their subsequent secreted antibodies, memory B cells, memory cytotoxic T cells, and active cytotoxic T cells, and see what evidence we have right now for the immunity that we garner from infection with SARS-CoV-2. So now we are positing that this could be an actual reinfection. Historic analysis, unfortunately, has shown that previous coronavirus infections do not appear to promise a long-lasting adaptive humoral immune response. We do know that the severity of COVID-19 illness does correlate with the level of specific antibody response. Fortunately, seroconversion occurs in approximately 95% of patients who present with infection. Unfortunately, it looks like there is a decreasing neutralizing antibody response at 3 months. On the contrary, immune memory does persist all the way up to 5 to 8 months, and we will discuss those next. Here's a longitudinal observation that was done on the neutralizing antibody response in the 3 months following a SARS-CoV-2 infection in humans. As you can see, multiple of these graphs have a waning amount of the antibodies in the system at 3 months. We will focus in here on the IgA and the IgG of the spike protein. As you can see, there is a waning response as previously discussed at 3 months. So the question is, will this last? Here is an immunologic memory study to SARS-CoV-2 that was assessed at up to 8 months. As you can see on the left, 1 to 2 months out, it would appear that a good portion of the patients have at least 5 pillars of the adaptive immunity still in place. At 5 to 8 months, most of these still have some portion of their adaptive immunity, though there has been a shift with how many pillars they still retain. This begs to question, do we build long-lasting adaptive immunity to the novel SARS-CoV-2 virus that is capable of thwarting off reinfection? This case represents a possible reinfection of SARS-CoV-2 and its associated COVID-19 illness. Positive long-term immunologic data, given the novelty of SARS-CoV-2, is present, and more studies need to be carried out over a longer period of time. We should all consider COVID-19 reinfection on the differential for cases where patients present such as this. Here are references for review. Any questions?